Hi everybody and welcome to the London Dental Academy. The London Dental Academy was established back in 2018. The purpose of establishing this academy was to offer our colleagues and dental students, whether undergraduates or postgraduates, some enhanced training in different domains and subjects in restorative dentistry, including implants, endodontics, and prosthodontics. The plan also to include some further courses, hopefully within this year or later in the summer, to introduce more courses in short orthodontics, hygiene therapy, and some other courses, short courses, especially around the hot topics around aesthetic dentistry. My name is Shihab. I'm the founder and the director of the London Dental Academy. I'm currently working as a consultant in restorative dentistry at Queen Alexandra Hospital in Portsmouth. And also I work in private practice in London, where I do some specialist work in restorative dentistry, advanced implantology and periodontics, along with endodontics and prosthodontics. I'm registered specialist in restorative dentistry, endodontics, periodontics and prosthodontics with the GDC. And also I'm a qualified dentist in the United States of America since 2004. To give you just short background of my training, I did my registrar training at King's, Guy's and St Thomas Hospitals in London between 2008 to 2014, and I completed my training back in 2014, where I was appointed as a locum consultant restorative dentistry at the University Dental Hospital of Manchester, and then a few months later I moved to Portsmouth Hospital. Prior to that, I did a few years training in oral maxillofacial surgery in Essex, South Wales and the Northwest. And also I worked as a teaching fellow at the University Dental Hospital of Manchester in oral surgery, sedation and restorative dentistry. Currently I split my time between the hospital and practice, and also pay a lot of my time towards teaching and training our young and colleagues, and also some other experienced colleagues, especially in advanced practice of implantologies and restorative dentistry. So my time is divided between the hospital and practice, as I mentioned. I practice all domains of restorative dentistry in endodontics, implants, periodontics, prosthodontics, and also in the hospital I do oncology and maxillofacial reconstruction, especially for cancer patients. The practice of the hospital is quite unique and different, especially most people, as we can see in these pictures, they have got some hemimandibulectomy or rim resection. Sometimes we find partial maxillectomy, or sometimes even we can come across significant loss of the facial structures like the noses or the orbital excentralization, along with some other parts of the face as well. So my focus on hospital service is to bring the quality of life back to these patients, and also to improve their facial aesthetics along with their functional status and quality of life in general. I just would like to show you and share with you some of the work which we do at the hospital, just to give you an idea. Like this gentleman in his early 60s was diagnosed with SCC mid-face, which was resected, along with also he had some, as you can see, cancer on the anterior maxilla. The resection took place through a lip split technique, where we had the nasal resection along with the anterior maxilla, and this is an image of the immediate reconstruction with obturator and some silicone material just to fill the space and improve the swallowing of this patient. Along with that, we reconstructed as well his face with a provisional prosthesis. During the surgery, or time of surgery, we placed few implants, as you can see, 2 zygomatic implants and 1 glabellar implant. These implants connected with a framework, as you can see, and this is made of gold bars, as you can see, as in a triangle shape. The whole purpose of this is to get the patient stable facial prosthesis and obturator to seal the oral cavity from the rest of the nasal cavity and improve his swallowing and also his phonetics. The post-operative graph, as you can see, the position of the zygomatic implants and the glabellar implants all linked together, and the link as actually will help to stabilize the prosthesis, the extraoral, intraoral, and also to consolidate the framework in general, quite significant size, as you can see. Our plan also to send this for a milled framework in order to get more sophisticated retention through locators and magnets in the intraoral and extraoral respectively. And as you can see, this is the position. The patient has got good quality of life since we fitted this provisional framework. And as you can see, the patient had some good smile and some provisional silicone prosthesis replacing the nose with some eyes covered with the spectacles in order to improve the retention and also to give him some natural looking as well. Moving forward, I think there are some cases where we do some reconstruction for the mandible. As you can see here, almost full resection of the mandible reconstructed with double DCA flaps, and we did reconstruction of the lower arch with the provision of 6 implants and full arch bridge. Sometimes you get cases where you have got partial maxillectomy, where you would struggle if you don't have enough teeth on that side, and zygomatic implants play a significant role in getting better retention. These implants could be linked with conventional implants, especially anterior region, as you can see in this case. And we have got another implant there to replace that tooth. The major function of this framework is to give retention for the obturator, improving the aesthetic and the function, and most importantly, the patient will have better phonetics and better oral function in general. Along with that, we have got like some cases with immediate placement, as you can see, which could be straightforward cases or associated with some sinus lifting, whether it's a microsinus lifting or a lateral window techniques, or replacing some teeth, like especially in hypodentia patients, trauma patients, and these quite frequently being practiced in our units and also in private practice as well. So quality of life and people experience quite important. People appreciate what we do for them in terms of the significant reconstruction and building their facial features, along with giving them good oral functions in terms of phonetics and swallowing, eating, and chewing. And most people rank the oral function as the first priority after the cancer treatment, especially the surgical treatment, since these people being most of the time left with debilitated quality of life, and they struggle quite a lot in order to get their functions back. So the implants actually find a major role in terms of reconstruction, and at the London Dental Academy we pay a lot of attention to how to reconstruct the dental structures, the replacing missing teeth, and also to have a comprehensive holistic plan for such patients, especially those coming with severe tooth wear, periodontal disease, and along with other medical factors like dry mouth and medically compromised patients. So we take, I would say, comprehensive approach in rehabilitating such patients. So back to our subject for the first, I would say, webinar for the London Dental Academy. We will be talking about aesthetic and functional management of tooth wear. We will discuss the clinical challenges and dilemmas which we might face. So I'll take you through a journey. Hopefully will take probably between 40 to 50 minutes on discussing some cases and the clinical management of tooth wear in general. So what are the aims and the objectives of this webinar? First of all, to go around the diagnosis, treatment planning, and passive management of tooth wear in primary dental care setting. We will be talking about Dahl Concept, especially when we have got localized tooth wear, And then we would talk about the management of localized tooth wear and the management of generalized tooth wear, which is more complicated and needs a lot of advanced and set of clinical skills. And that's what we'll be focusing during our training at the restorative care courses at the London Dental Academy. So first of all, let's specify our aims and objectives to get our CPD by watching and answering some questions after this seminar. And also this is normally what we do in our seminars as well, to offer our students and dentists and colleagues E-CPD quality assured in terms of the content and in terms of the evidence-based practice. So the aims to discuss the clinical dilemmas and their management in relation to tooth wear, to develop evidence-based knowledge in the etiology diagnosis of tooth wear, and to be familiar with the passive and active management of tooth wear. So hopefully by the end of this talk, you will be able to understand the principle of Dahl concepts in the management of localized tooth wear, to understand the implications of occlusal derangements and occlusal issues when we tackle such cases, especially by opening the bite, changing the occlusal scheme, and looking into more advanced cases, and to understand the clinical principles in the management of generalized tooth wear, which is quite different from Dahl concept and localized tooth wear. The adult dental health survey, which was done back 2009, indicated that 77% of our population, dentate adult population, suffer from tooth wear, mainly in the anterior teeth. 15% of these people showed moderate tooth wear, more extensive dentine exposure, and 2% suffer from extreme tooth wear, which could involve dentine and secondary dentine at the pulp. When we talk about 2% here, is quite significant figure. If you're looking at a population like London, we have got 10 million people. That would account to a significant number of patients suffering from those tooth wear, from the tooth wear problem, and those people will probably struggle to find the resource or the right place for them to be treated, since this treatment quite complex and takes a long time, and also needs a lot of training, especially from the dentist side, to manage these patients in the immediate, short and long term. So looking at the graph here, as you can see, more people as we get older, more tooth wear, and unfortunately nowadays tooth wear is quite endemic, especially with the older population, and with aging population we will face even more severe problems and more complex problems, and that might be an issue also for our healthcare system, and how could we cope with such a group of patients for the next 20 or 30 years. What's the trend in the area where I work in Hampshire? We did a small audit, and looking at the number of referrals between 2016 2017, and what we found that 77% of our patients referred for prosthodontic reasons and on prosthodontic I would say merits in order to rehabilitate these patients. And when we looked at the tooth wear, as we can see, it's almost, as you can see, 50% of these people having some problems with their dentition, whether it's been worn down, whether it was mutilated, or some, as you can see, teeth are missing, and could be associated with other cases like difficult partial dentures and, for example, difficult treatment in terms of getting them good quality of life, since these people medically compromised. But in general, I would say the tooth wear is the most dominant element in our service and also the referral. We don't normally take people for treatment in the hospital, but I think in the academy we're trained dentists in order to get around and hopefully circumvent all the challenges they might face in the practices, in order to equip them with the skills, knowledge and the evidence in order to get better understanding how to deal with these complex patients. Moving forward, I think all of us will come across such cases. And this is probably coming within moderate to severe. I would say moderate tooth wear in the upper arch, probably more severe in the lower arch, especially we have got secondary dentine, as we can see in the lower central incisors. And we have got loss of OVD, I would say. There is element of overclosure, reduced lower face height, if we look at the facial profile. So when we look at these people coming with not only with one complaint, like just for the teeth are short, but also they could suffer from symptoms like in terms of sensitivity, pain, discomfort if there is loss of vitality, and also functional problem, difficulty with chewing, eating, cutting food, and people looking at the whole picture as quality of life. Some of them saying to me, and haven't been able to smile for the last 10-15 years, haven't been able to socialize, my social life screen being significantly damaged or affected. So there are some social elements to the problems. So what are the signs and the symptoms of people coming with tooth wear? And how is the presentation normally in the population or in our daily practice? A study done by a group of researchers in Liverpool back in 2012, they looked at the referral and they found over 50% of the people referred or the patients referred are male patients who significantly presented with tooth wear compared with the female, just only 31. So there was significant difference between males and females. With the likelihood of being male is quite higher. The aesthetic concern was the most prevalent factor, and the complaint was mainly to do with the short teeth or the damaged teeth or the missing teeth in general. And the sensitivity was the least or the second most common presenting complaint, less than 40%. Functional problems and pain are less relevant, but I think most people had some sort of loss of vitality, and that could come up to some studies 17%, some other studies to 13%. And also the tooth sensitivity, especially in a young patient with eating disorders, might be an important factor when you have got aggressive tooth surface loss. What they found quite interesting, that most people, especially the elderly patient, they've got severe tooth wear, there is loss of posterior support. When I say loss of posterior support, normally there is element of reduced OVD, and also there is element of missing teeth in the back. As I mentioned earlier, having some periapical pathology as incidental finding, that could be up to 13%, and as some studies indicated, like in this patient, we have got the upper right one after completing the treatment for tooth wear, found that this tooth, because was asymptomatic, having radiograph later on, we found there is root canal treatment needed on this tooth, which has achieved and built the tooth up with direct composite restoration along with the fiber post. So what do we need to know about tooth wear, and how do we manage tooth wear, and what are the threats or the opportunities available for us, whether we work in NHS practice or private practice? Actually, we need to understand what is tooth wear and what are the etiology, what are etiological factors contributing to tooth wear, how could we attribute it, because knowing the tooth wear and the sources and the reasons of tooth wear is quite important and key in order to get the right diagnosis and develop the right treatment plan for this patient. Diagnosis quite element is not only the diagnosis based on the clinical presentation, we might need to look at the patient's history, we need to look at the patient's habits, we need to look at the other factors, the social elements quite important, not necessarily now, but could be 20-30 years back when the patient probably had severe or heavy consumption of fizzy drinks or alcohol or eating disorder or or other conditions or even medications in the past. Some of them could cause some element of tooth wear. In order to liaise with our colleagues and specialists, we need to have some elements of knowledge how to classify tooth wear and what are the classifications available for us. So in order to construct, I would say, a rapport with the patient and also with our colleagues, and having a better referral system in place should we need to refer the patient. We need to know the treatment options. When should we involve in treatment? When we should not involve? When should we are able to intervene intervene where, or sometimes we don't need to intervene just to monitor. I think it's quite tricky and one of the gray areas in the management of tooth wear, because people think that in such cases they keep the patient for a long time without intervention, which is might be wrong. Some other people would like to intervene even with the monitoring, and some sort of passive management might be sufficient. So let's look at some cases just to show you and demonstrate what are the differences between erosion, abrasion, and also later on attrition and abstraction. These lesions, as you can see, young patients with some enamel, as you can see, lesion in the cervical region on the upper central incisor, lateral incisor, and the canine. Looking not very, if you look from I would say from outside you might not notice, but looking closely and just close up these pictures, you will find there is a loss of enamel, and here even the dentine is exposed, although the enamel in this area normally is the thinnest in the tooth structure, but there is, as you can see, importance of that, because that might, once we get the dentine, might go further with some abrasive brushing that might deteriorate quite quickly and rapidly and could cause some issues. Therefore, we need to look into the factors which cause this problem. Some people could be some sort of fizzy drink, not drink it straight away, rather than swishing the fizzy drink in the mouth, keep it for a long time, and the long intimacy between the fizzy drink and the enamel might cause this problem long term, and we see that quite often, especially in the palatal surface of the teeth, where the fizzy drink being kept between the tongue and between the palatal surfaces of the teeth. And to have a close-up view, that would demonstrate the significant loss or damage to the enamel. And also, if you look at this lateral incisor, you can see with the dentine, and this is similar to what we call them sometimes the abstraction lesion or non-carious cervical lesion, but this is a frank enamel loss due to erosion, due to acids. And it's quite important to understand the etiology, because this is a key for the short and long-term management. The management of these cases might not be necessarily difficult, but we need to understand how can we go through it and how we assess it properly. I think in the practice we need to pay attention to our new patients, people even kept for a long time. We need from time to time to have comprehensive looking and examination and assessment, recording all these through pictures, or even if you have got access to intra or a digital scanner, that would be great. So that is a good way of monitoring should you decide to monitor. If you look at the palatal surface on the same patient, seems to be there is element of, as you can see, erosion on the palatal surface. There is significant loss. And if you can look at the tooth here, there is a ring of enamel there, and that would indicate that there is element of erosion, because that enamel kept safe. As you know, enamel is not as easy to dissolve as dentine, and normally around the gingival margin is more protected and the saliva is there but as a buffering factor. But looking at the back here on this retained E and the 6, there is a little bit of, as you can see, spot there which is brown. It's quite important to understand whether the fizzy drinks are sugary or not sugary, and then that through as well the caries, if there is element of caries along with that. In more severe and significant cases like this, as you can see, young patients, we need to understand that the presentation is quite important. The patient's complaint, patient's concern is quite important. By looking at this, as you can see, there is element of secondary dentine. The pulp chamber always, as you can see, showing through it. You feel like you are inside the pulp, but not necessarily, because the sclerosed dentine normally coming as you can see, that type of presentation, which showing that filling the pulp chamber without having a direct involvement of the pulp. The radiographic assessment is a key here in order to exclude and rule out any sort of periapical pathology. But again, looking at the tooth and testing the vitality through cold testing, electric pulp testing, these are quite important elements. Although you can see, but don't try to, if possible, to try to probe these areas, because sometimes you've got thin layer of dentine you might break through, rather than you have to protect, and this area to be protected is quite important, and that could be done with a thin layer of resin composite to start with, rather than damaging the secondary dentine. As you can see, the presentation, as I mentioned, always looks like a transparent dentine covering this area. As you can see, there's element of the dark area, could be secondary caries, and whenever you find restoration, open margin, you might find such a presentation as well. So how would you plan? How would you treat? It's not only about the anterior teeth, it's not only about a couple of teeth. Always I would look at the whole picture, see what's going on, and how would if you look at the same patient who's 35-year-old female patient having significant tooth wear on the palatal surfaces, on all upper teeth, withering of enamel, as I mentioned before, almost more than 50% lost. This is coming as class 3 to 4 Smith and Knight classification. As you can see, the incisal edge is quite thin, translucent enamel due to the loss of dentine. The posterior, this is very, very thin. We need to protect this unsupported enamel as soon as possible, otherwise we're going to lose it. Is a key for future reconstruction. And also there is a reduction in the OVD and lower face height, which should be addressed at some stage. Looking posterior, the problem is more pronounced, significant tooth wear on occlusal surfaces. That definitely will indicate that there is some sort of more generalized problem, and that could be a element of eating disorder in such young patient. And we need to look out and to watch out for such patients, especially young female patients coming with silent problem. Then we need to investigate and to look into their eating habits, sometimes in denial, sometimes in treatment. Sometimes they come as a presentation like there is element of eating disorder, and that has to be referred to a psychiatrist or a upper GI consultant or unit to investigate whether there is element of eating disorder. So the gastrointestinal medicine would have a role in this, in managing this problem. If it's eating disorder, then it depends whether the patient is bulimic, is anorexic, and then the psychiatrist also might play a significant role in helping us managing such problems. So is this pathological or histological or physiological? I think looks at this young age, most likely this is pathological rather than physiological, and the management due to being pathological has to be more, I think, active type of treatment rather than just symptomatic treatment, because there is a significant risk here for the loss of the whole dentition, which will be more problematic in our side rather than the patient side, because getting people to be rehabilitated at this young age is quite challenging, let alone the cost factors and the management and long-term management for these people and maintenance. So looking at this, you can see there is a V-shaped lesion on the cervical region of these teeth. Again, there is, you might say, element of abrasion, as you can see, but again, I think it's always necessary to look at the patient's diet, the patient's lifestyle. Although it might be significant abrasive material or technique or brushing technique, but again, I think to start with, there must be some sort of element of erosion, and we need to look into these factors, because always we have to how this problem started. Yes, abrasiveness into this region would contribute, but the most important, what the combining factor, and I think most of the time we find it is multifactorial between abrasion and erosion, and we need to address it that way. Of course, treating these cases quite challenging as well, especially with terms of bonding, the margins, but should be actually treated, because leaving these teeth would undermine the vitality and the integrity of these tissues in general, as you can see here. And what reiterate my point that there is brownish type lesions, and I think this element to start with, loss of enamel, of course, caused by acids, but the technique of brushing or the abrasiveness of the material being used for brushing these teeth might have contributed and exacerbated the problem quite significantly. So we need to look into the element of erosion or erosive problems, and also we look at the fractal developmental disorders and within the enamel dentine, and whether the lesion is reversible, irreversible, pathological, or physiological. All these cumulative factors over a long period of time would complicate the matter for the patients. Within the normal limit, probably as Lambert's as estimated 20 to 38 micron a year, but the pathological is normally is multifactorial and is quite rapidly progressing through the patient, especially young patients. Um, so looking at this more advanced case, it's looking diagnosis of this case. It should not be uh, complex because I think most of these cases, as I mentioned earlier, multifactorial. There is a combination of attrition, erosion, abrasion, but challenging cases sometimes like this, it's daunting for the patient to leave him like this without having treatment. Yet it's quite difficult from our point of view. How would we manage these cases if we're going for any sort of indirect restorations, although he has got a very healthy component of periodontium around the teeth and doesn't seem to be periodontal involved in the periodontal support's quite good. But again, what sort of restoration, what sort of occlusal scheme we'd like to establish? How could we build the lower anterior teeth with such severe a tooth wear? These teeth could be bonded, could be built and then crowned if it's needed, but this is quite challenging as difficult as you can see. But even with indirect restoration to start with, I think having any sort of indirect restoration, you might compromise the tooth structures which already being compromised, like this tooth, for example, this upper right one, the upper left two, the upper left three. As you can see, the bite and geometrical shape, which has since the loss of the anterior guidance, most of the guidance coming on the canine, as you can see, and that indentated the tooth in a shape similar to the lesion on the lower arch, and that probably all the lateral guidance coming onto these teeth in the canines and on other anterior teeth to even complicate the problem further. So what's the difference between this lesion and this lesion? As I mentioned, the difference might not be significant in terms of presentation, but the etiological factor here, most likely there is element of internal acid production, and we need to look into that quite carefully in terms of the if there is any acid reflux, any sort of gastrointestinal disorder or eating disorder. But here, most likely, although there is element of erosion, but most likely there is element of abrasive material, abrasive technique going in cleaning these teeth. And as I mentioned, there is element of dentine, as you can see here, intact, and some unsupported enamel on the edges here, which we need to support and to treat as soon as possible. The management here is more difficult, more complex than this one, is more involved because I've got reduction OVD, we have got some anterior teeth to be built and to be aesthetically built. Some, as you can see, this is fracture in the corner here, probably most likely from the fact that the enamel, unsupported enamel, being knocked out by the bite or by something biting on something hard. So we're looking at erosion, attrition, abrasion, and abfraction. All these factors, all these elements could be combined together as a multifactorial problem. Looking at the same patient I discussed earlier, 35-year-old female, and looking at the posterior teeth, what's the element of tooth surface loss tooth wear here? Is most likely erosion. Here there is an element of erosion, but also abrasion. And remember, this young patient probably trying to brush her teeth I would say in a very aggressive way, very difficult, very strong way, which could cause such a problem. Scrubbing the teeth, especially in the back teeth, with the abrasive toothpaste and toothbrush might cause such problem. Now, looking at this mid-50 gentleman, I treated a long time ago. It's most likely, as you can see, ring of enamel intact, cupped out lesions with exposed dentine, class 3 to 4, Smith and Knight classification, pronounced and proud amalgam. As you can see, there is a loss of the canine to canine plus the premolar region. This is most likely because these lesions are not straight, it's quite cupped out. There is an element of proud amalgam and surrounded by ring of enamel. Is most likely is erosion. And here as well, there is element of erosion, but most likely there is element of abrasion. Some people attributing these lesions to abfraction, which is a normal, sometimes of stressing the teeth at the neck due to the functionality and to the probably the paroxysm or the guidance. The evidence is quite weak, but again, management should not be that different. So we're looking at the extrinsic erosion. Most likely, as you can see, it's due to the environmental factors, as like drinks and fizzy drinks. And this is just a short video to demonstrate how the tooth could be dissolved and the enamel would be reduced, and due to the exposure to the low pH in the oral cavity. Moving forward, the intrinsic, and as I mentioned, the gastroesophageal reflux disease could be one of the factors which need to be investigated and need to be looked at very carefully, and referral needs to be just showing you this short video. So as you can see, just demonstrating how Hiatus hernia and esophageal reflux disease could happen. So basically this GORD, what we call gastroesophageal reflux disease, one of the main factors which we need to look at and to refer the patient when is required. So going back to the basic question, is the management of tooth wear static or functional? What is our role as dentist specialists in DCPs in managing such people? I think there are wide variations in terms of managements. People, some parts of Europe going for indirect restorations, and United States probably most of the time they go for indirect ceramic restorations. The trend in the UK, we go for direct restoration using resin composite to bond, which I think I found it very predictable in the right hand when you've got the sufficient training for bonding and layering the composite in the right way and maintaining the composite, and of course establishing the right occlusal scheme for each single patients we treat. So going into that, say if I would say this case which I received recently, coming through the door to your practice with, I would say, mild to moderate tooth wear, where's the main problem? Is it to do with the severity of the problem? Is it to do with the occlusal scheme? Is it to do with the difficulty with bonding? I think most of the time that dentists complaining that we can't bond to these teeth. Of course we can't bond if we don't adopt the right bonding strategy, if we don't understand how the occlusal scheme works, what sort of bonding do we need, and where about to bond our restoration is quite important. Is it in the front? If I do it in the front, like straight away, like in this case, using Dahl Concept, what's going to happen to the posterior? Do we have enough teeth in the back teeth? Do we have a predictability that will work, and we have some sort of over-eruption and intrusion on the anteriors? Dental alveolar compensation, is it predictable? What's the age of the patient? There are many factors, and I think these cases could be challenging and could be daunting for the patient as well, since they're causing a lot of frustration. But the whole aim from our point of view is how would we able to treat such patients in predictable period of time? how would you manage these patients for the long term? Because basically this patient spent almost 20 years going to the practice every couple of months to have these restoration rebonded. And I think I wouldn't here, I would say, blame any of our colleagues or managing such cases, but rather is to look comprehensively. This is quite a complex problem because we need to gather a lot of information. We need to establish sort of management plan could work in the short and the long term. Therefore, I think training and reading and getting the evidence always in our back is quite important in order to support our strategy or the management strategy. Regardless of where you're going here, whether you're going for generalized full mouth rehab or doing just restoration of the anterior, is the key is how would you manage your occlusion, the force distribution, and also how would you manage the missing teeth and posterior, because that's quite important role in protecting our restoration along with the establishment of reasonable occlusal scheme. As I mentioned earlier here, just to direct you towards our courses, we did some restorative courses back 2019, and based on our success, we continued as 2020. We have got restorative comprehensive courses over 6 modules, which will have 6 days of hands-on training at the Weybridge, where we have got the London Dental Academy. There we will welcome all our colleagues and our students to come and to attend these hands-on training on the diagnosis, treatment planning, occlusion, articulation, and also direct and indirect restoration, bonding, layer composite, anterior posterior composites, along with some implants training and restoring endodontically treated teeth. So more information, you can visit our website on lda.academy. And also we offer some training in endodontics. We have got 6 modules in endodontics, from access cavity to restoring endodontically treated teeth and implants, as well as 6 modules spanning between treatment planning, placement, surgical management of bony defects, soft tissue defects, along with restoring implants with provision of fixed removable restorations, and also managing the complications along with reporting CBCT and 3D software planning. So the most difficult thing is decision making in any medical and dental problem. But decision is not only based on our preference, on our expertise, but rather is based on the evidence. What is going to work, what's not going to work, what has worked in the past, what might likely to work in such certain case. And along with that, of course, we have clinical expertise, and training is quite important. We need to make sure that's all done properly. Patients' values and patients' preferences need to be taken into consideration, because some people might say, I'm quite happy with this level of tooth wear, I don't want some treatment, but other people with less significant and less severe tooth wear, they might request treatment and actively pursue a course of treatment you might offer them. So are we able to treat such cases? I think in a primary dental care setting, there are some limits, and there's some also understanding that the patient need to be referred to specialists. But I think as a matter of, I would say, from clinical governance point of view, from we need to diagnose the patients, we need to tell the patient what is going on, we need to put a provisional plan to start with, like such cases, you can see severe erosion in all teeth. These we need to find out what happened to the patient now and before, while as we have got severe, as you can see, attrition, and as you can see, the enamel completely gone, is straight, as you can see, bite line here with reduced OVD, wide diastema. We need a lot of missing teeth. We need to address these issues, because I don't think here Providart composite will work very well, but here might not necessarily work without having posterior support and re-establishing, opening the bite and re-establishing at least coming back to edge or a class 1 incisor relationship. So always decision making is the most difficult bit. But in such cases like this, localized tooth wear on the anterior region might be less challenging than the previous cases. Even when we're going to do a treatment for the palatal surface like this, but sometimes we can see the teeth quite short, stained, I would say mottled sometimes if there is some sort of fluoride element, aminogenesis element. So we need to get into the patient inside, the patient preference as well, and look and address the aesthetic issue. It's not only addressing the functional, but rather building sometimes the anterior teeth with direct composite veneers or indirect veneers. Something would be required and would enhance the patient's self-esteem and aesthetic and overall the treatment outcome from the aesthetic point of view. Now, what are we going to do when we don't have enough interocclusal space, we don't have interarch space, we don't have enough tooth tissue to build to? I think the first step to start with, we need to understand what is the occlusal scheme, and taking decent depression, articulating in RCP position, the most reduced contact if we can, without putting a lot of pressure in terms on ourselves, finding where we're going to put these restorations, how can we find, are we able to find any horizontal sort of spacing between the upper and lower arch in order to accommodate my, I don't think that should be a priority at this stage. Rather, we're having some sort of right checks and also looking at the occlusal scheme, what could be done, what are the impact, for example, these wax ups on the posterior scheme. As you can see, these are just in function in the process of developing nice and good wax up for the anterior teeth. Like this young patient whom I discussed early today, 35-year-old, building the anterior region or the anterior teeth with direct composite buildup would enhance the height-width ratio. The anterior guidance, as you can see, most likely going on the upper central lateral incisor, and the canines will come into action when the patient going into lateral functions. So we need to understand the static and dynamic occlusion very well and how it works. And in this case, if you don't have posterior support, then it becomes a problem. But a managed direct build-ups using Dahl Concept, I think, is quite predictable. We need to have enough information how it works, how long we need to monitor the patient, what are the side effects, and how would we manage it in the short, long term, because it's quite important from consenting point of view and converting these people from direct restoration into direct restoration long term and invest in our building is not only the profile of the patient's smiles and but the profile of practice and the business in general, because it's quite important revenue for the practice as well. So how much can I increase? I think the question is not about 1 or 2 or 3 millimeters. There is no one size fits all, but it depends how much do I need to build the teeth and how much I can get the teeth back to the original contour. This is the question, and I think in these cases sometimes you can see here significant opening of the bite. That will not bother me at all as long as I understand that I've built the teeth to original contour, I have got enough posterior support and the occlusion being controlled properly. At later stage, if I want to move on to any sort of other restoration, that be possible. But as you can see, probably one session doing such work and getting such result for the patient is quite rewarding, but is not to be complacent as well at the same time. But we need to be more careful, and so we look into this in the short and long term in the management of the occlusion and to monitor the posterior over eruption, and if there is no posterior over eruption, is it possible to do some direct buildups as well in order to get the teeth back to occlusion. Most likely these teeth normally are the premolars sometimes getting difficult. In such case, localized tooth wear, severe wear, as you can see in the palatal surfaces of the upper incisors along with the premolars, especially on the left and the right hand side. As you can see, direct composite buildup on one session might be a good strategy for such cases and getting the patient into Dahl, and I think that would work very well, especially when you do this with the understanding of the patient that the back teeth will over erupt over time. Might take some time. If not, then there is option to go and build some of the posterior teeth if it's needed. Most of the time that is not needed, and the occlusal scheme will work very well, and dental alveolar compensation will work. So the Dahl concept, just to explain it into details, as you can see in this case, we have got localized tooth wear on the incisal palatal surface of the anterior teeth. We will start normally, I would a little bit rush into this presentation or this webinar. I think the details of the hands-on training will be available on our website, and also the hands-on training and the restorative course will be starting soon as well. We'll take you through all the steps, how to articulate, what sort of articulating, what Facebook registration do we need, how to manage the occlusion, what sort of occlusal scheme we need to do, and how to do the wax ups. And I think it's quite important if you do your own wax ups sometimes, especially in the beginning. That would help you to have some very good skills in the clinical skills, especially with the hand freehand techniques or using the matrix. That's what we're doing here. Fitting the matrix, the putty matrix, separating the teeth is quite key, because if you don't do that, you might get all the composite stuck. You will spend all of your time separating this composite. There are many techniques and various techniques available, but I think this is one of the most practiced techniques, using the matrix or using the from silicone or from I would say transparent silicone as well for the light curing. This is normally what we do our training with, using the matrix, different types of putty matrix or matrices, separations with metal, with as you can see, with mild strips or other techniques which we'll show you during the hands-on training. Bonding is a key, and I think the fourth generation is a gold standard for our bonding, using one of the fourth generation like Clearfill SE bond is one of the actually predictable ways of doing bonding. So we etch, we prime the surface, and then we bond, and we start layering our composite. And with layering as well is a very significant part of our hands-on training, building the palatal surface and then forward from the darkest to the most translucent, or to lightest and translucent enamel at some stage. And as you can see, straight after finishing, you can see the gums is still covered with bond. You don't need to count. When you come back again a few days later, you will see that you will be able to get better margins. And also posteriorly, you need to monitor the Dahl. Actually, Dahl is not old. It's been in practice for many years. Normally we start with a cobalt chrome prosthesis or device being put in the anterior region in order to close. So basically Dahl should be practiced or should be placed wherever we need the space. There is limited interocclusal or interarch space, then has to be placed. Might take up to 24 months. We need to remind the patient that the success of Dahl is quite predictable, but it might take a long time to get the right occlusion or occlusal relationship. The thickness normally relates to the amount of interocclusal space is required, and success, as I mentioned, is between 94 to 100%. And the patient's compliance is a key, and patient understanding and consenting is a key, because this has to be explained to the patient in details, pictures and videos if possible. Some work taken from the BDJ, as you can see some pictures where there is no space for a bridge, as you can see, a bonded metal framework or some context with a bonded in the anterior region into the supraocclusion has created some space, which lately this will be replaced by provision of resin bond bridges or conversion bridges or implants. So intrusion normally is 40% over eruption of the other teeth, the teeth which over erupt about 60%. The over eruption is most important than the intrusion, because once you get the over eruption, I think the occlusal will be and the restoration will be stable. And over eruption normally takes place than intrusion in young patients. Posterior contacts usually more established or re-established in the molar region, followed by the other teeth, especially the premolar. Sometimes it might take longer. If not, then we need to build these and bring them into occlusion if necessary. Yes, that's all about Dahl Concept. Hopefully that would be again explained to you at the restorative course at the London Dental Academy. So what are the contraindications? There are some factors which we need to consider. People coming with hypermobility teeth, mobile teeth might not be suitable for Dahl. People with some TMJ symptoms, again, might not be suitable, especially if they think that might cause them, or you might think that might cause them further problem or complication, especially with the people with parafunctional activities and parafunctional syndrome. Root resorption, post-orthodontics, and periodontal involved patient, I would rather advise to avoid them, because the dulling these teeth will increase mobility and might result in loss of these teeth. So occlusal being re-established might take some time, but the most important thing, the dental alveolar compensatory mechanism and the neuromuscular proprioception will be established as well in due course. The space, I think I would not be restrictive here, mentioning, I must mention here 5 mm or 6 mm. It depends on the patient, depends how much space we need, and most important, how much space we need to recontour the teeth quite predictably. So contraindication, I would say occlusally aware patients like phantom heads we need to avoid, because these people will feel every significant or every change you might introduce to their bite and their occlusion. Periodontal involved teeth, mobile teeth, reduced bone support, especially post-orthodontics. I think it's better to avoid these situations. Patient education and explanation, demonstration quite key for consenting and for the successful management. Sometimes these tooth wear you will have a significant also occlusal changes, like this gentleman here has got a class 3 due to the, it could be skeletal and also due to the severe tooth wear surface loss due to the anterior rotation of the mandible. Reduced OVD contributed to this, along, as you can see, he recently lost the upper left one. So a combination of direct composite buildups and replacing these teeth could take place as a provisional measure. Building the, as you can see, the teeth with direct composite, along with fiber being stacked in the pontic side and built up with composite, will give the patient a reasonable, I would say, outcome in terms of correcting the occlusal scheme by moving it from class 3 incisor relationship to edge at least to probably class 1, replacing the tooth for the time being, getting some posterior support that would help to take off the pressure and the guidance as well. Along with that, we need to be careful when we do establish the guidance here. We get into as many teeth as possible, and the anterior lateral guidance on the canines is quite difficult to establish groove function in such patients. And this is after the immediate rehabilitation, but again, that need to be revisited, having some more posterior support, and also looking at the restoration in terms of the, because this would be still provisional, especially with replacement of the upper left one. Localized tooth wear like this on the upper central incisor canines, again reduce OVD. Sometimes we start, but when do we start with Michigan splint or as you can see, stabilization splint? I think when you have got element of probably attrition, there is element of suspicion that the TMJ or the patient acceptance for increased OVD, or some symptoms as well need to be addressed in the beginning. I think that's is quite legitimate to start with, but most of the time, if you've got element of attrition, this as I think post treatment needs to be, the patient needs to be fitted by one of these. I would not do it in people with a significant tooth wear caused by erosion. As you can see, composite buildups, Dahl Concept, posterior, as you can see, separation, which will hopefully within a few months' time recompensate and having a nice over-eruption of posterior and intrusion. The patient, I think I monitored this patient almost for 10 years and I never had any problems. The only thing, the composite started a little bit discoloring and she requested some indirect restoration at some stage. Yes, as you can see, the guidance on the central incisors, if you want to engage the lateral incisors, is possible, but this is quite difficult sometimes, especially if you have to have nice aesthetic. I think he gets the routine deciduous teeth which could be built and kept for the time being. The lower anterior teeth has been from 5 to 5 actually has been built. So yes, it's quite important. As you can see, this is 2 years after, but I monitored this patient longer than this, as far as a long time ago. It's quite a decent outcome for the patient, even the deciduous teeth being built up, all the occlusal scheme, and you can see being re-established quite satisfactorily. Generalized tooth wear is a different breed, different problem. I think, as you can see, this case, which you need to build all the teeth if you're doing, I would say, direct restoration. If it's indirect, then it has to be lab-based studies in terms of wax-ups, provisional restorations, and then converting the provisional restoration into more definitive indirect restoration, and that would require a lot of skill and techniques, and also support, let alone the fact that costs would be phenomenally expensive from the patient point of view. But a lot of people would rather having indirect restoration. So I would say my strategy, do the direct restoration, especially strengthen these teeth, re-establish the occlusal relationship, and then probably if we want to go ahead with indirect restoration, that's quite possible, because as you can see, we build the teeth quite significantly, and preparing the teeth for indirect restoration will not necessarily remove significant or losing the vitality of these teeth. But again, I think we need to look into these teeth. As you can see, it's very difficult to get them managed with indirect restoration. So it's quite balanced strategy balanced views of managing. So Facebook is quite key, especially with generalized tooth wear, even with localized, if you want to understand how to establish. There are many articulators and Facebooks out there. I would use the most common ones, for example, the Archons is most practiced and available in the market. There are some types of like hinge, semi-adjustable, fully adjustable Dana articulator, quite commonly used in dentists. I use it mainly for dentures, but there are out there many types of articulator. It doesn't matter as long as it's reliable. Took all the measures, and I would say there are some sort of set readings and measures need to be looked at, and I think if you have got the Facebook has to be compatible with the Facebook has to be compatible with the articulator, so you need to have some sort of communication with the lab. If you want to open the OVD, I think the pin to be dropped down. Look at how much you need to do, and then you need how much restorative material you need to build, and developing your what they call it, Lucia jig, or the anterior guided plane is quite important, and that would help you if you want to customize it at some stage. I think that all will be discussed, technical information about occlusion and customization and wax-ups and mock-ups on the restorative course at the LDA, which will be coming soon. Michigan split, again, is another type of treatment. Most of the time, if you have got severe attrition or complex rehabilitation with full mouth rehabilitation, Michigan split is needed. Or some people coming with some symptoms, which I found it quite useful. People using it for many years can get off of it, but most important, we need to achieve the objectives of a stable occlusion, and that would be having mutual posterior support, anterior guidance on the upper anterior teeth, and lateral guidance in the canines, and most important thing, all coming together. As you can see, the black spots and the RCP has to be matching the ICP in order to get the, what we call it, the mutually supported occlusion. And as you can see, this is Michigan splint in situ. Even we have got missing teeth, doesn't matter, we can include them in our occlusion scheme and getting more support, working like basically like bridge. And as you can see, the lateral guidance on the canines, the anterior guidance on the anterior teeth, the mutually protected occlusion as well by the as many contact as possible. And nowadays even could be produced by through the 3D printing, and there are some sophisticated scanners and printers to print PMMA Michigan splints or stabilization splints. So how much do you need to get the patient managed of composite? It depends. There's subjectivity there, but I think the wax-ups and the mock-up will give us a good idea how much we need. A stabilization splint sometimes, as you can see, is necessary to start with. Sometimes not, depends on the etiology. With generalized tooth wear, as you can see, building the composite, as you can see, all the teeth, and the anterior starting with short period of time to posterior to avoid any fracture or smashing the anterior restorations, and then later on, if we opt to go for more sophisticated indirect restoration, that could be possible, especially with the new generation of lithium disilicate and monolithic zirconia restoration. GORD, I think, need to be referred, as mentioned, to GP or gastroenterologist or psychiatrist or psychologist if it's needed, if there is element of eating disorder. But the most important thing, we need to have remineralization by fluoride therapy, adhesive restorations, and using long-term direct and indirect restoration is a key. Like in these cases, you can see significant tooth surface loss being managed with direct composite buildups. And I think on all surfaces, it's like a sandwich being applied on all these teeth. I think this is quite a good strategy for the short and long term, especially with relatively old patients. Again, another case here, we have got, as you can see, wide diastema, class 3 to 4 on the upper anterior teeth, Smith and Knight classification. Building these, I think, direct composite buildups, as you can see, quite good, but most importantly as well, having posterior support. And the Glamy and Hemming study indicated that the median survival rate or time for these composite restoration almost 5.8 years. and that was on 26 patients having 283 composite restorations. And I think, in my humble opinion, these restorations will last quite significantly if the posterior support is provided and the occlusion being managed very, very well. And as you can see, people please, as you can see, dark dentine to nice shade of composite might be another bonus. Bonding strategy, I think we need to adopt the right bonding, finishing, polishing, which will be discussed in details in our course, and layering composite as well, which will take me some time to go through, and this will be available on our website. These are courses you can book at some stage. A direct composite layering technique, again, I think that's something we can discuss during the hands-on training, but let's discuss this case where we have got some missing teeth, erosion, and attrition element on the upper and lower anterior teeth. I think managing this case is quite complex because of the nature of the bite and the posterior support, as it's not great, but building the composite, increasing the OVD, that would transfer and transform actually the patient's smile, let alone the fact would transfer the patient from this edge to edge to class 1, doing composite build-ups. You can see lower anterior teeth, upper anterior teeth, and then followed by the posterior support, removing the teeth with bad prognosis is a key as well within the context of the treatment. Another one, class 2 Div 2, as you can see, quite difficult because of the guidance and the nature of the guidance and the limited space for the posterior. And such people, it's good to start with bleaching of these teeth. Vital bleaching is key, using 10% carbamide peroxide and bleaching trays, direct composite buildups to erosion contour, posterior support, and I think the strategies will work very well. As you can see, reduce OVD, class 2 Div 2, as mentioned, it's quite challenging, but again, the treatment with direct, indirect, with some bleaching, I think, is quite key, and this is few years after the treatment and the partial denture or implant restoration. The problem is when you get these people being treated with such composite without having posterior support, or even if you want to treat them with implants, you don't have enough space posteriorly, then becomes a problem. So the skill of managing occlusion and managing tooth wear is useful and financially rewarding as well if you want to treat and tackle more complex cases. Again, sometimes you don't have tooth tissues to build up the whole tooth, therefore going for a partial denture, as you can see, or overlay denture might be useful to get a reasonable yet functionally and aesthetically pleasing outcome for the patients. This case, young patient presented with diastema and a retained root upper left 3, limited space for the upper left 3. So what our strategies do we have? I think building, as you can see, the anterior teeth with direct composite buildup. As you can see, actually we did the centrals and reshaping of the enamel, just enamelplasty on this tooth here, and we use a technique called canonization of the upper left premolar by having a resin bond bridge, as you can see, using as you can see, metal ceramic materials to replace the 3, and that will work very well because we took the function away from the canine. At the point it becomes function free to the premolar, which becomes working like a canine to replace this missing tooth. And as you can see, most of the functions coming into the premolar, and kept the canine a little bit shorter, but it's not too short. As you can see, it's quite nice, but most of the guidance coming in the premolar with full protection, and there is a, as you can see, a metal wing and occlusal coverage, which will help to take the function and also help to replace the tooth at the same time. I think at later stage, if you want to replace this tooth after doing the Dahl treatment on the upper left 4, then a single implant crown will work very well. Since we established the occlusal scheme, we open the bite, and also we establish all the parameters which might help us with the implants. Lower anterior teeth, as you can see, building the lower teeth, this case we have to build the anterior and the posterior at the same time. As you can see, the composite buildup is quite significant. Therefore, sometimes you need to have indirect restoration. That time, long time ago, we did not have such sophisticated material like monolithic lithium disilicate, so probably I would approach these cases differently nowadays, especially with the advances in technology and bonding and material available to us, like the monolithic zirconia and the lithium disilicate. Sometimes, as I mentioned again, looking at the case with severe case of tooth wear, you need to consider the patient getting the information how much we need to build up the teeth, but most importantly, as I mentioned, up to 13% you have got radiolucent lesions and radiolucency around the teeth. Therefore, I have to manage this for the patient before I start anything. So this is why I did the root canal treatment on the lower central incisor, as you can see. And the endodontic is quite important part of the Dental Academy training. We have got 1 year, 6 modules over 6 months' time. And I think in terms of getting access, as you can see, cleaning and shaping root canal system, microscopic examination of the access cavity, and finally the canals, getting the treatment, that's the key for healing of such big lesion. I think this is actually quite rewarding because the patient doesn't need to lose this tooth, and building this tooth quite predictable, especially in this case I opted to do indirect restoration. Therefore, after doing the direct restoration, we did a crown lengthening, and as you can see, all ceramic crowns. It's been monitored for a while. Composite buildups on the upper anterior teeth, indirect restorations, all ceramic lithium disilicate on the lower teeth is quite, as you can see, pleasing from the aesthetic point of view. The patient used to be on antihypertensive drug, which we tried to put him off in order to reduce the, as you can see, gingival hyperplasia in this region and improve the oral hygiene in general. So this is before, this is after. It's quite it's good strategy here. We're combining the direct and indirect, reducing the cost of the patient and improving the outcome for the patient as well. So space management is quite important. We need to look at the midline, available space, how much do we need, gingival tissue biotype, especially with overbuilding, rebuilding, if we need to do anything, and looking at the session potential, patient expectations, young and old patients, our clinical skills, our training, lab as technical support, and affordability, who's going to pay for the treatment. It's quite complex, long treatment, oral hygiene, patient's compliance, quite important, and the lip line as well, and what we're going to do, whether we need to do any sort of electrosurgery, gingivectomy, laser treatment, or crown lengthening. That all depends on the patients. So there are a few factors. We need to, first of all, start articulating study models, taking radiographs for monitoring and for photographed as well as pre-op and post-op to audit our work, and also to show the patient what happened. Wax-ups and max-ups quite important for getting informed consent. Closing diastema, I think there is a video here on hands-on how to do it. It's quite technique sensitive, and again might be not sufficient. We don't have sufficient time at the moment to discuss it with this webinar, but hopefully with the hands-on training you will get all the training and materials how to do it predictably. Bonding, I just go through it. Hopefully it will not take long, but I'll try to go through it because there are a few principles in bonding. We have to wet the, we call it the substrate very well. Dry and wet it has to be one, and the surface tension of the adherent, which is the monomer, has to be less than the energy or than the surface energy of the adherent, which is the tooth. Normally the enamel is having high energy than the monomer, but most of the time we don't have enamel, so we need to make sure it is wet and receptive for the monomer in order to getting the wetting effect. The contact angle between the monomer and substrate of the tooth has to be close to zero, and the exchange process of the inorganic material is replaced with the monomers. It's a calcium phosphate depleted from the hydroxyapatite and then replaced with some monomer. As you can see, the bonding is calcium phosphate removal, and monomer will be infiltration in order to get what we call a chemical bonding along with the micromechanical. With the functional monomers, we have got three types. We have got the 10-MDP, 4-MET, and the phenyl P. Research has shown, as you know, that 10-MDP is the self-etching hydrophobic functional monomer, is more stronger than other monomers, and capable of forming strong ionic bonds by depleting the calcium and doing the they call it the chemical bonding, and that due to the low solubility of the 10-MDP compared with the 4-MET and phenyl P. So the functional group have self-etching, but it's not very much strong self-etching. It's just mild, I would say, the 1.5, 1.7 pH, to have partial demineralization of the dentine and to improve the dentine wetting and prevent collagen from being collapsed. That's the most important thing. And then the viable calcium ions will bond with the within the hydroxyapatite depleted collagen will bond to the monomer, forming the what we call it the chemical bonding. So the hybrid layer is not necessarily within the dentine. Also within the enamel, we have got the enamel prisms being, as you can see, etched, demineralized, and having the micro and macro tags. With the dentine tubules, as you can see, is quite important, but most important than the dentine tubules, the interfibular infiltration of the monomers, as you can see. It's not only dentine tubules, but was going around the dentine tubules with the interfibular infiltration of our monomers, with, as I mentioned, has to be low energy towards the compared with these two surfaces. So formation of resin tags quite important to get the chemical and micromechanical bonding. We need to remove the smear layer. We need to condition the surface very well, getting the wettability of the surface, zero angle, and then get the longest resin tags possible, the dentine tubules as well in between. What we call the contribution of interlocking adhesive resin within the collagen into fibular space network and micromechanical is considered as far more important than the resin tags. This is the resin tags going inside the dentine tubules, quite important, but what's going around the dentine tubules is far more important, the interfibular space of the collagen network. In terms of bonding, we have got three scientific classification: etch and rinse, self-etch, and glass ionomer. In terms of the commercial, we have got 4th, 5th, 6th, and 7th. I think the gold standard is the 4th generation. We were etch, prime, and bond. 5th, we have got the prime and bond combined together. The 6th, we have got no etch because it's self-etching, mild etching. We have got 2 bottles, and the 7th generation, we have got functional monomer self-etching along with 1 bottle, which combines everything. So the indications of bonding could be rewarding in terms of closing the diastemas, as you can see here, doing direct restoration like direct composite buildup, sometimes fiber posts and composite cores, and restoration for endodontically treated teeth. Could be building cores, could be fissure sealants, could be even a bridge like a fiber, direct fiber, resin, and composite bridge work, which we normally use for orthodontic patients, most of the time missing laterals. Finally, I will say thank you very much for joining me in this webinar and having all the time listening to my talk about managing tooth wear. But as just to finish, these are the courses which are available on our website, the short and long courses. So from the your perspective, you don't have time to attend the whole module restorative. You can attend some of the modules, for example, the occlusion and face bow, articulation, management of tooth wear, anterior, static restoration like lithium disilicate preparation, temporization, and scanning, the posterior monolithic preparation, provisualization, and also the cementation technique for monolithic zirconium. With the endodontic, we have got from access cavities down to the irrigation and instrumentation, obturation, restore endodontically treated teeth, along with the surgical endodontic treatments. And with implants as well, we've got different courses in single, multiple implants, soft hard tissue enhancements. So hopefully you have enjoyed your time with us, with me today, with listening to this presentation about tooth wear. But most important thing in dentistry, I just remind you that everything starts with perseverance. In the beginning, it might be difficult, might be daunting, but at the end of the day, I think we need to develop the passion to love what we're doing, and that will keep us going for the long term and of our patient the best results, and also for us to get the job satisfaction we're looking for on a daily basis. Thank you very much for listening to me, and I look forward to seeing you on the